Welcome, everyone. I'm Liz Stewart. I'm chair and professor in the Department of Biostatistics at Johns Hopkins and co-director of the methods core of the Johns Hopkins ALACRITY Center, along with Beth McGinty, who joins us here as well. As a little bit of background, I will give a little background on ALACRITY and our presenter today, and then we will turn to the presentation. So welcome to everyone. Just want to introduce you to this webinar series. This is part of the Johns Hopkins ALACRITY Center's Advanced Methods for Mental Health Services Research webinar series. It's part of the series where we have a few different webinars on statistical methods of relevance and other methods of relevance for mental health services research. I'll put a link in the chat to the website where we have links to previous sessions, and you can learn more about that. So as a little bit of background on ALACRITY, saw that we've been joined by Gail Dommett, who's the PI of the Johns Hopkins ALACRITY Center. The center, the full name is the Johns Hopkins ALACRITY Center for Health and Longevity in Mental Illness. It's funded as part of the National Institute of Mental Health Advanced Laboratories for Accelerating the Reach and Impact of Treatments for Youth and Adults with Mental Illness, which turns into the acronym ALACRITY, P50 Centers Program. So our center at Hopkins is particularly interested in advancing short and long-term strategies to reduce premature mortality in the population with serious mental illness. We also have a particular focus in our Hopkins Center on methods for mental health services research. So we in particular do research, training, community partnerships with this goal of speeding translation of effective interventions to improve physical health among people with serious mental illness and translate those to everyday practice. As I mentioned, today is part of our methods seminar, methods series, which is part of the methods core of the center. And I'm really thrilled to introduce Nick Seewald, who will present this webinar on target trial emulation for evaluating mental health policy. Dr. Seewald is an assistant professor of biostatistics in the Department of Biostatistics, Epidemiology, and Informatics at the University of Pennsylvania Perelman School of Medicine. He develops and applies statistical methodology to answer key questions in public health and medicine through thoughtful study design and analysis, combined with deep collaboration with applied scientists. And I think that's really kind of captures what we really try to do in the ALACRITY methods core overall. Related to that, before moving to Penn, Dr. Seewald was a postdoctoral fellow at Johns Hopkins, where he worked on a variety of statistical methods topics related to mental health and substance use research. And before that, he studied at the University of Michigan, where he earned his PhD in statistics, a master's in statistics, and a master's in biostatistics. So in terms of logistics, we welcome you to put questions into the Q&A. I will monitor those throughout the talk. We will likely hold questions for the end. So we'll have about a 50-minute presentation, and then we'll have time at the end for Q&A, which I'll kind of monitor, maybe try to answer some using the Q&A function. But please do put questions in there, and we'll have time for that at the end. So again, welcome everyone. So glad you could join us, and I will hand things over to Dr. Seewald. Thank you.
Thanks, Liz. Thanks for the wonderful introduction, and thanks to everybody for being here. It's a real pleasure to be doing this. And a pleasure to see so many folks in the audience. Just a quick little plug. I am a former trainee of this ALACRITY Center, like Liz mentioned, and currently leading a project with the methods core. So it's very exciting to be involved in this really important work, and it's exciting to see so many people show up and be interested in methods for advancing their own work in mental health policy. So let's kick things off by just sort of framing a question here. So when we talk about policy evaluation, we want to make sure that we understand sort of what we're asking here. So in general, the goal of policy evaluation is to answer questions that look like, what is the effect of some policy on some outcomes of interest over some defined period of time relative to what would have happened in the absence of the policy? So there's this sort of Mad Libs structure to this general question, and there are a lot of pieces that go into this. We need to think very carefully about the policy that we're interested in, the outcomes that we're interested in, the period of time over which we're interested in evaluating those outcomes related to that policy. And then also embedded in here, as we'll see, is a counterfactual question, because we're asking about what would have happened relative, asking a question about what did happen relative to what would have happened had the policy not gone into effect. And the goal of policy evaluation is really to fill in all of these blanks. And the goal of this talk is to describe a framework for helping you fill in these blanks and answering questions of this form. So policy evaluation is, in general, pretty hard. There are a number of key challenges in policy evaluation that can be really difficult to overcome. First of all, it can be hard to isolate the policy of interest. States or organizations or municipalities, policy implementing units, often don't do things in a vacuum, and they do things in quick succession. So policies go into effect, and they're not necessarily being designed or implemented to be studied. And so really disentangling the effect of the thing that you're trying to study can be a real challenge. The other thing that happens is that there's confounding by time. So oftentimes, if we're studying multiple units that implemented a policy of interest, they're not going to implement that policy all at the same time. There's maybe some staggered adoption of the policy. And if there's sort of anything underlying, any sort of trends happening in the background, those trends can also make it difficult to evaluate the effects of the policy because there's maybe an alternative explanation for any changes in outcomes that we see. Policies vary a lot between units, state to state, for instance. Policies designed to tackle the same issue might be implemented or designed in very different ways. And so understanding and unpacking that heterogeneity can be a challenge. And also, we're often limited to small sample size in policy evaluation. So for instance, if we're thinking about a mental health policy that's being implemented at the state level, and it's being implemented by a variety of states in the US, we have a sample size of at most 50, which can be challenging. So some ways to overcome these problems, or these challenges rather, is to think really carefully about high quality study design. And so the framework, or this methods webinar, is really designed to introduce you to a framework for design of high quality policy evaluation studies. Thinking really deeply about design and designing a high quality study can help eliminate or alleviate some of these concerns about isolating the policy that we're trying to study from other things happening at the same time. This confounding by time issue, where we can maybe isolate the effects of the policy from underlying secular trends. Thinking really carefully about heterogeneity, policy heterogeneity, is also really useful in this design framework. Also throughout, I'm going to really advocate for the use of qualitative methods and the blending of the qualitative and quantitative methods together to give us a better understanding of, for instance, the policy that we're trying to study, when that policy gets implemented, and the effects or the lack thereof of the policy that we see after the evaluation. And so a useful framework for thinking about high quality non-experimental study design is called target trial emulation. And target trial emulation is really a design framework for thinking about non-experimental studies that's going to enable a stronger design, facilitate communication about that design, and facilitate causal inference about the policy that we're trying to study. It's a very simple idea. At its core, it's basically an invitation for you to think really deeply about the randomized trial you would run if you could, but you can't, and then designing a non-experimental analog that gets as close to that hypothetical target trial as possible. This is a method that's really common in epidemiology and is seeing really broad adoption in epi and some other literatures, but the framework is very broadly applicable. And we're seeing increasing adoption of it across different fields, in particular policy evaluation. But I want to clarify that just because this has the word trial in it does not mean that it is a trial, and it doesn't mean that it's magic. So thinking about a target trial framework does not guarantee a quality trial emulation. It's just a way to think about setting this up in a way, or and designing your study with a guide that can make it a better study. Throughout the talk, I'm going to be essentially discussing ideas that are reported in this paper in Annals of Internal Medicine that I co-authored with Beth McGinty and Liz Stewart, who are on the call as well. It's called Target Trial Emulation for Evaluating Health Policy. I'm pretty proud of it, and I think it's a nice explanation in words of the ideas that we're going to be talking about in the webinar. A small warning, if you are familiar with target trial emulation in other contexts, we are focused here in this health policy setting, and health policy applications often require different considerations than studies of individual level interventions. In particular, because policies are inherently cluster level interventions, they require natural experiments. And so we need to see the policies get implemented before we can think about the questions that we can ask about them. We often have small sample sizes, which is counter to a lot of the big target trial emulations that we see in, say, the epi literature. And also we have this setting here where the units that we're studying, the units that are implementing the policy, are often not exchangeable. They're states, they're clinics, they're meaningful units that have different characteristics, and those different characteristics are important to consider. For instance, we can't necessarily just like pick somebody out of Texas and move them to California and say everything is the same except for the policy, that there's other things going on there. So the practical reality of policy evaluation requires trade-offs that at times may deviate from the ideal target trial framework, but we'll talk about ways to overcome that. So there are 7 key components of a policy trial emulation, and we'll walk through each of them in turn. The first component are units and eligibility criteria. We also need to think about defining the exposure and comparison conditions we'll study, how those conditions are assigned to different units. We need to think about time, baseline or time zero, and follow-up. We need to think about the outcomes that we're going to measure and study, the causal estimand, and then finally, the statistical analysis and the assumptions that go into that analysis. You'll notice that the first 6 of these components all happen before analysis. They all happen before we even think about statistics or like a statistical analysis. They're really thinking very carefully about design, and then the analysis comes afterwards. So let's walk through each of these in turn. The first component that we'll think about are the units and the eligibility. And so really the question that you want to ask as we think about this are, who are we studying? Who is our question about? In a policy trial emulation, we have to think about 2 levels of units. We have to think about units that are at the policy level. These are the units that could implement the policy or the comparison condition. And then we also need to think about units at what we have called the impact level. These are the units that the policy is designed to affect and on which outcomes are measured. And so typically what will happen is there's some sort of superstructure, some organization that is going to implement the policy. This is the policy level unit. And then there are impact level units, very often individuals, that are nested inside of that policy level unit who experience the effects of the policy and whose outcomes we want to measure. Typically, these levels will be different. We'll have, for instance, we'll see a running example of a clinic and then patients at that clinic, or a state and then individuals who live in that state. So oftentimes the policy and the impact levels are different. And in this case, or when they are, our trial emulation is going to emulate a cluster randomized trial and not an individually randomized trial. These levels may, however, be the same. There are some situations in which the policy level unit and the impact level unit are the same. It's a little bit tricky to think of. The cleanest example that I have is something like a budget resolution or something like a budget where maybe a state changes funding for its mental health organization, and then we want to study some outcome on the mental health administration or program in that state. But oftentimes we're going to be thinking in this nested setting. So let's consider each of these levels separately. So in a hypothetical policy trial, the policy level units would be the units that could implement the policy. So these would be states, clinics, organizations, something of interest. And remember, by policy, I mean something very broad. This could be something like a law, but it could also be sort of a mandate from a clinic leader that you implement a particular procedure, or like a hand washing mandate, something like that. So we're going to think about the units that could implement that policy. And then in our hypothetical trial, we're going to monitor those units longitudinally. So I would follow those units before and after they implement the policy, and I would collect outcomes throughout. And these units would be eligible for my trial based on information that I have collected prior to policy implementation. So this would be things, criteria like units that have not implemented the policy before, or something more complicated, like they haven't implemented the policy before, but they have implemented some other set of policies, or they have a particular, like, a robust EHR system at the clinic level, something like that. So we wouldn't be deciding the units that get included in our study based on anything that would happen after we assign treatment in our hypothetical policy trial. However, in a policy trial emulation, we are sort of in now a bit of a retrospective framework. And so our policy level units would be the units that did implement the policy of interest, or that did implement the comparison condition that we're using at some time zero, or at study entry, ideally. We'll come back to this. And we would still monitor them longitudinally. So we're going to look back and identify policy level units that implemented or did not implement the policy at the time that we would hope that they would implement it, and then sort of retrospectively look back over a period of time. The units that we would be considering as eligible for our policy trial emulation should be based only on pre-policy information. So we should only be looking at say, clinic features or other like unit level characteristics, policy level characteristics that happen before the policy gets implemented. Ideally, we'll again sort of run into some complexity here. So those are the policy level units. The impact level units are those that are nested inside of the policy level units and that are designed and that would be affected by the policy if it was implemented. And so in our hypothetical policy trial, this would be either the policy level units themselves or these subunits nested in the policy level units on which our outcomes are measured. And ideally, our impact level units would be from the population the policy is designed to affect. And so if we're implementing a policy that's designed to affect only individuals with serious mental illness, ideally our impact level units, the people that we follow in our trial, would just be individuals with serious mental illness. Again, eligibility for inclusion here should only be based on pre-policy information, like lives in state X for policies, a state level policy that applies to everybody, or some other additional features like they live in state X and they were diagnosed with some condition Y before the policy was implemented. And then because we're in a trial setting and we're looking prospectively here, we would have some retention efforts. We would try to maintain the individuals in our study if we're following them longitudinally. In a policy trial emulation, the same considerations apply. We want to think carefully about who is affected by the policy, recruit people from that population by thinking about pre-policy eligibility criteria, and think carefully about how we might mimic retention efforts over time. Additionally, we would be thinking about having outcome data that's available from the impact level units. This can be challenging. We'll talk about that challenge in just a second. But as an example, just to make this a little bit more concrete, let's think about a study that's designed to examine the effects of a state policy that allows specialty mental health programs to create so-called health homes, where these programs can bill Medicaid for delivering cardiovascular care management services. The policy level units in this example would be the specialty mental health programs that implement or don't implement this cardiovascular care management program. And the impact level units would be the patients with serious mental illness who visit those clinics. So let's now talk about data. This is sort of, we've established what the policy and the impact level units are in practice. And now we run into this issue in policy trial emulation where we have to use data that's available. We're not necessarily prospectively collecting data. And so the quality of your trial emulation is in part determined by what data you have available. Very common in policy evaluations, we work with so-called group panel data. And so this is sort of data that's aggregated over multiple time periods up to the policy level. And so we might have things like, state mean outcomes at monthly, for instance, and not have data on individuals. And so if we have such aggregate level data, and it's not exactly from the target population that we're trying to study, this can weaken our trial emulation because we're unable to restrict our data to be from the impact level units themselves, and we might have a more general population. If this data is aggregated up from the target population, so we have, say, aggregate level unit time data on just our target population, so just individuals with serious mental illness, for example, this is great. Or if our target population is very general, if our impact level units are sort of the general population, and we have aggregated statistics at this time, or at that among the general population, also totally fine. But we want to be careful here because we want to think about using data to restrict ourselves to the data or to the population that we're targeting. If we have data at the impact level, so for instance, if we have insurance claims or like Medicaid claims, and we can identify diagnoses in individuals, and we can restrict ourselves to only looking at claims among individuals with serious mental illness or a particular diagnosis that we're interested in, we can restrict ourselves to the target population. And so we can use we can get a stronger study out of that because we're able to look only in the population that the policy is designed to affect. The other thing that we need to think about is longitudinal follow-up of these impact level units. So in policy trial emulation, we would follow impact level units longitudinally, or we could have repeated cross-sections of individuals. And deciding which of these you want to think about or use in your trial changes the sampling frame. So oftentimes we see these so-called continuous presence or continuous enrollment requirements. And this would require an individual to be in the data for the entirety of the trial, which is a way to mimic high-quality retention efforts in a randomized trial. But if the exposure affects the probability of your continued presence in the data, this is probably inappropriate. On the other hand, not requiring a continuous presence in the data probably leads to maybe missing service use because people drop in and out of your EHR or of insurance coverage, something like that. And it also allows your patient case mix to change over time. And so this presents a threat to internal validity. It threatens our ability to attribute the effect or any changes in outcomes that we see to the policy instead of the changing case mix. However, it improves external validity. The population of individuals who are, say, enrolled in commercial health insurance over 7 years is very different from the population of people who are on commercial health insurance sort of in a staggered way or come on and off. Weighting can help overcome some of this external validity issue, and there's methods for that as well that are outside the scope of this webinar. But really, we're thinking about generalizability and the sampling frame here, and so it's important to consider this. So those are our units. That's our first component of the policy trial emulation. The next component that we want to think about is defining the exposure and comparison conditions. So here we're going to try to answer the question, what are we studying? We just answered who are we studying. Now we want to know what we're studying. And so in a hypothetical target trial, if we're thinking about defining an exposure and a comparator, the exposure would be one policy that all of the implementing units would be assigned to implement. We would have some group of units that would be assigned to implement the policy, and that policy would be pre-specified. We would know everything what's going on. We would just hand it to them and they would do it. The comparison condition, also in our hypothetical trial, could be a specific alternative policy, or it could be just business as usual, just carry on as you have been going before. This is completely unrealistic, or not completely, often extremely unrealistic in a policy setting, because people don't necessarily, like it's very hard to assign policy randomly. And so in a policy trial emulation analog, what we're left with is sort of this retrospective situation where the specific details of every policy that gets implemented by all of the policy implementing units can be quite heterogeneous. And so specialty mental health clinics might implement this cardiovascular care management in different ways or to different extents. The programs themselves could look quite different across all of our units. And so it's important to think carefully about what we're actually studying. And a framework for thinking carefully about defining the exposure and thinking about the policy that we're interested in is called legal epidemiology or policy mapping. It was laid out in this paper in the Annual Review of Public Health in 2016 by Burris et al. And the idea is that we're going to introduce a lot of qualitative methods here. We're going to qualitatively and systematically look at the policies that were implemented by all of the units that we're studying. And we're going to identify a class or a small number of classes of similar policies that will be the exposure. So we want to think very carefully about what are the core features of the policy, the policies that get implemented. What are the core features of this that need to be included in order for a unit to be considered exposed to the policy here? We want to think very precisely when defining this exposure, because we want to use the definition of the exposure to disentangle it from other things that are happening at the same time. So we want to disentangle the effect of the exposure and other things happening by maybe carefully defining a time period in which the exposure occurs, or a lack of other policies being implemented around that same time. So we want to use this sort of legal epidemiology framework to map the policies that exist and identify those core components of the policy that we want to study. If it turns out that there is sufficient heterogeneity, or you have like a number of clusters of policies that are all targeting the same thing, but do so in a slightly different way, we could actually emulate a multi-arm trial where we have like sort of multiple policies that are slightly similar, but just a little bit different, instead of just a two-arm cluster randomized trial. So that's thinking about defining the exposure. When we think about defining the comparison group, this can be quite challenging. Best practices for trial emulation would say that at time zero, the comparison group is every policy level unit that has not been exposed at that time. And then if those unexposed units, if those comparators become exposed later, if they actually implement the policy later on, then we'll censor their outcomes at the time that they implement the policy, but they'll still sort of be included. This is sort of making concrete that idea that we can't use post-treatment information to define eligibility. However, this ideal design is not always practical for policy evaluations, in part due to challenges around sample size. So there are two types of comparators that you'll often see discussed in the policy evaluation literature. And it's important that you think really carefully about which comparators you want to use, and that you really carefully justify that choice based on scientific knowledge of sort of the policy landscape, among sort of other things. So we want to think about two potential groups, the first being the group that's unexposed at baseline. So this is the sort of ideal setting here, where we are avoiding conditioning on post-treatment information. However, this allows the comparison group to change over time. And so if we have a group of comparators at one time, and then they start implementing the policy as time goes on, our comparison pool potentially shrinks over time. And if those units that eventually implement the policy are quite different from the units that never implement the policy, this can lead to sort of meaningful changes in the comparators over time that makes your effect estimates early on sort of qualitatively different from the effect estimates after a bunch of those comparators drop out, for instance. So if we think of a state level policy, right, maybe we're comparing California to a very large pool of states early on, and then as time goes on, a lot of those states implement the policy themselves. And then towards, after a few years, we're left comparing California to, say, Idaho. Those are very different states. And so that comparison towards the end of time kind of lacks face validity a bit. And so we're left with this challenge where we have to decide whether any observed effects that we see are due to the policy or due to the changes in the comparison group. On the other hand, we could just select the comparator units that are never exposed. We could look ahead into the future and say, okay, these are the group of units that have never implemented the policy, and we're going to use these as our comparators throughout. That's a group that's chosen using knowledge of future policy status, which could lead to bias if you're not careful. This is not ideal in target trial emulation framework, but because that comparison group remains unchanged over time, it is a potentially attractive option because it lets us isolate the effect of the policy from the changing comparison group. And so if you want to use the never exposed comparators, you need to be very careful to justify this choice. Like I said, just to go into this a little bit more, studies that choose to use the never exposed comparators are subject to additional assumptions about the comparability of those units that are ever treated and the units that are never treated. And because of that, those assumptions, they are subject to additional risk of bias. And this choice does deviate from the ideal framework. So if you want to avoid this, we could change policy level eligibility criteria. We could go back to component 1, and we could exclude likely bad comparators based on, say, geography or urbanicity, et cetera. But we do want to pay attention to that remaining sample size. We could also limit our follow-up period to one in which good comparators exist, so that we only follow up long enough with that California example to, well, California still has like a reasonable face valid pool of comparators. The third component we want to talk about is the assignment mechanism. And the question we want to address here is, how did units decide to implement or not implement the policy that we're studying? Well, in our hypothetical target trial, we would randomize them. We would have a cluster randomized trial. And so we would possibly stratify that randomization. And we would randomly assign units to implement or not implement the policy of interest in an unblinded way. I don't know how we could do this in a blinded way. So it might be possible, but it's almost certainly unblinded. And this is unconfounded by definition. Definitionally, there is no way that anything else can influence the assignment here because we're randomizing. However, in our non-experimental policy trial emulation analog, we are not randomizing units to implement or not implement the policy. We are typically emulating cluster randomization here, but again, we can't randomize. And so there is the risk of confounding here because that assignment is going to be affected by both known and unknown characteristics of those policy level units. And again, this will be unblinded. The units will know what they did in the past. So that's assignment. We want to think just very carefully about potential confounders there in our trial emulation analog. The next component to think about is baseline or time zero. And here we want to identify when units decided to implement or not implement the policy. This can be quite tricky in our non-experimental setting, but in our hypothetical target trial, it's fairly easy. We would know when we randomized the units to implement or not implement the policy, and we would have done a bunch of recruitment and prep for the implementation prior to randomization. And so as soon as we flip that coin, the policy would be able to be implemented essentially immediately. In our trial emulation analog, we need to think carefully about when the policy could start impacting outcomes. It's not necessarily the day the policy was enacted or the day that the legislation was signed. It's when outcomes could start being affected by the policy. So for instance, in our billing example, it would be the first day that Medicaid allows billing for the cardiovascular care, not necessarily the day that the governor signed that legislation allowing it. This is fairly straightforward to establish for the policy implementing units, but for the comparators, it can be quite difficult because we have to identify a time at which those comparators could have implemented the policy, but in fact didn't. So let's think about what that means. We want to be very careful in defining our baseline or time zero because defining this in a bad way can lead to bias because we could inadvertently condition on post-treatment information. We are also probably working in a setting where we have what's called staggered adoption, where different policy implementing units implement the policy of interest at different times. So Pennsylvania passes a policy on one day, Maryland does it on another day, etc. This staggered adoption setting can lead to more complexity. And so one solution here is to use what's called serial trial emulation. And the idea is that we'll define a baseline or a time zero for each policy implementing unit, and then use those baseline times to define a series of baselines for our comparators. And what this does is it creates multiple trial emulations, one per unique implementation date. Let's see what this looks like. So in the first panel here on the left, I have two treated states, 1 and 2, in solid lines on the top and bottom here. And I have 3 control units in dashed lines in the middle. The asterisks on these timelines for the treated units represent their implementation date. So TX1 implemented before TX2. What we'll do here is we have, in thinking about sort of a follow-up period, which we'll discuss in a minute, we will take each treated state's implementation date and the study period that we'll define, and we're going to map it onto the control units. And so for TX1, I'm going to take its study period and its implementation date, and I'm going to draw it down onto the controls. And so I end up with one kind of trial where controls 1, 2, and 3 would have implemented at this time. Same thing for TX2. I'm going to map their implementation period up onto the controls. And so I get a second set of, or a second trial where TX2 implements at its implementation date, and the controls are also assigned to have implemented the policy, or its time zero would have been at that same time point. And then what we do is we just take these and align them in relative time. So the implementation times move out of calendar time and become time zero, and then we line everything up. So we have one cohort with treatment state 1 being treated and all of the controls having time zero at that implementation date. And then we have another cohort of states where treatment state 2 has its implementation date and the controls also have that same time zero. So that's a way to think about baseline. Next, we want to think about our outcomes and our follow-up. We want to address the question of what are we measuring and when are we measuring it? The outcomes here are interpreted at the policy level. The outcomes will be things like proportions, means, etc. for each policy level unit. It will be the proportion of patients with serious mental illness who are receiving cardiovascular care at this mental health home. Or the mean number of, or say mean weight loss for individuals who have been attending sort of a group-based session for individuals with serious mental illness with cardiovascular disease risk after some period of time. So it's going to be, all of the outcomes are sort of at this aggregate level because of the cluster randomization and because these units aren't necessarily exchangeable with one another. This is really natural for group panel data. So if we have data that's pre-aggregated, the only thing that we can talk about are proportions or means. If we have individual level data or impact level data, we're going to just aggregate it up to the policy level, and then we'll talk about outcomes at the policy level based on that aggregate information. The other thing to think about outcomes here is that in our hypothetical policy trial, we could prospectively design outcomes of interest. We could think about exactly what measures we want to include, and we would, but in our non-experimental policy analog, we're in this retrospective setting. And so we are limited to what was collected sort of routinely in the past. So there's a slight difference there in potentially the way that we think about our outcomes between our hypothetical trial and our non-experimental analog. Additionally, we want to think carefully about follow-up time. So in a hypothetical trial, we would typically have one or few pre-exposure measurements. We'd have a baseline, maybe 2 baselines. However, in non-experimental studies, and in these policy evaluations, the validity of the causal estimate that we are able to obtain from our analysis often relies on a reasonably large number of pre-treatment measurement occasions. We need to be able to look at trends and outcomes before policy implementation and after. And so the pre-implementation period in our non-experimental analog needs to be quite a bit longer than we would have in a trial. We also need to think about post-exposure follow-up because we want to extend our post-exposure follow-up long enough after the policy is implemented in order to capture meaningful effects and changes in those effects. Maybe there's a delay in the effect. Maybe there's a steady ramp up or change, right? Maybe there's a strong effect at the beginning that tapers off. So we need to have a long enough post-exposure period to find those, but we also want to avoid potential issues with other policies being implemented. So because these policies aren't being implemented in a vacuum, maybe another policy that could really affect the outcomes is implemented a year after the one that we're trying to study. And so there we might be restricted in the amount of follow-up that we can look at without having the influence of this other potentially confounding policy. The sixth component is the causal estimand. This is how we're going to start thinking about a population level quantity that describes the question of interest statistically. This is where we translate science into statistics and causal inference. So in general, an estimand is just a population level quantity that statistically describes the treatment effect of interest. It's the thing that we're trying to estimate, described not in words, but in stats. Often, the estimand is a causal quantity that's going to describe the average difference between counterfactual outcomes in pre-policy level unit or in policy level units under the exposure and the comparison conditions. So we're going to try to answer a question about what would have happened under different states of the world. We're going to estimate the mean outcome in the policy level units after they were exposed, and the mean outcome in the policy level units had they not been exposed, counter to fact, and compare those two outcomes. There are a variety of broad categories of causal estimand, and we'll walk through 3. The first is the average treatment effect. And this is going to compare the expected counterfactual outcomes under exposure to those counterfactual outcomes under the comparison condition on average over the entire population, over all of our policy level units. The way that we express this statistically is it's the expectation of the outcome under treatment, so y of 1, this is a potentially counterfactual outcome, minus the potentially counterfactual outcome under the comparison condition, just on average over everybody. The second category is slightly restricted. It's called the average treatment effect among the treated, or the ATT, and it's going to compare the observed outcomes in the exposed group under the exposure to what would have happened had those units been unexposed. And the way that we write this is the same as the ATE here, but now we're conditioning on being treated. So we're only looking at this expected difference in counterfactual outcomes among the treated group. And it turns out that the counterfactual outcomes under the exposure, under the policy implementation for the treated group are just the observed outcomes. So we have to estimate the counterfactual under what would have happened, or for the policy implementing units had they not implemented. We could also flip this around and look at the average treatment effect among the comparators. So here we would compare the observed outcomes in the unexposed group to what would have happened had they actually been exposed. The ATT is typically targeted in policy evaluations by convention. In a randomized trial, all of these things are equal on average because of the randomization. But in a non-experimental analog, typically we're looking at the ATT. Sorry, I thought I had a slide on this. Just to clarify that a little bit more, the reason that we're focused on the ATT primarily is because we only have to estimate what would have happened to the exposed units under no exposure, and not also what would have happened to the unexposed units under exposure. For some reason, it's a little bit complicated, or there's like a little bit of a leap of faith that has to happen when you estimate what would have happened to the unexposed units had they implemented the policy. That doesn't come along with like what happened if the policy didn't go into effect. There's a little bit more sort of hypothesizing. It feels a little bit more uncertain to think about, say, the ATC. Or estimating what would have happened under implementation in the units that didn't implement. And so typically we look at the ATT, not necessarily because it's primarily of scientific interest, but because it's what we can get the best with the most reasonable assumptions. Now, finally, let's talk about statistical analysis. So up until now, we've thought about design, very careful design principles, and then we've thought about translating those our scientific question into a statistical estimand. And now let's talk about how to analyze data in order to estimate the estimand. We also want to think very carefully about the assumptions that we're making in this analysis. So our hypothetical cluster randomized target trial would just be a cluster randomized trial. And so you can go and pull off your favorite textbook about how to analyze cluster randomized trials, use those sort of standard textbook tools, and you'll do great. However, our non-experimental trial analog probably can't use these standard tools because the assignment is likely confounded. The reason that the target trial can use the standard tools is because assignment is unconfounded by definition. And so our goal here is to make some reasonable assumptions that will allow us to estimate the causal estimand, that quantity of interest. And typically, like I mentioned before, the methods that we're going to see used in this setting typically use pre-baseline information from both exposed and unexposed units to extrapolate an estimate of the exposed group's counterfactual outcomes under no policy into that post-implementation period. There has been a huge explosion of methods for this in the past years. For a while, it was feeling like there was a new paper like every week. My Google Scholar was just going crazy. And so there's an increasingly large class of methods designed to estimate policy effects in this setting. Very broadly, I'm going to talk about two classes of estimates. The first is the difference in differences estimator, which is commonly sort of instantiated as something called the two-way fixed effects model. We'll also talk about a synthetic controls method, but there are other ways to do this, including event studies, for instance, and you can introduce fancy matching and weighting somehow. Like there's sort of a very broad class here, but I just want to give you a little flavor of what's happening. The key thing to think about when you're deciding about an analysis approach is that different methods rely on different assumptions, and so you need to be very careful to make reasonable assumptions for your setting and change the method, perhaps, to make those assumptions more reasonable. So let's first talk about difference in differences, or DID. Basically, the big idea with DID is that you're going to compare the change in the outcome over time between exposed and comparison groups. The key assumption made here is called parallel counterfactual trends. The assumption says that the exposed group's outcome evolution would have looked like the comparison group's outcome evolution had the exposed group not been exposed. So in pictures, if we just have two time points here, we just have a pre-intervention measure and a post-intervention measure in a comparison group and a treated group, the assumption says that in the absence of treatment, the treated group's line would have had the same slope as the comparison group's line. It would have evolved parallel here. And so the causal treatment effect in DID is the difference between the actual observed outcome in the post-intervention period for the treated group to our estimate of what would have happened had they been untreated, which is just sort of looking at this counterfactual line here that has the same slope as the comparison units. So this is our treatment effect in classic two-period diff and diff. The problem is that that is a very simple setting where we have two units, one treated, one untreated, or exposed and unexposed, and just two periods. Oftentimes, we have this setup of staggered adoption where policy level units are implementing the policy at different times. So we might have a staggered program rollout, for instance. If we think about states implementing this, say, Medicaid billing example policy, maybe we have states implementing kind of approximately the same time. So maybe Arizona and Connecticut put theirs in at one time, Alaska, Colorado, and Delaware did theirs at another time, and then Alabama and PA did it later on. If we just use sort of standard, don't think about it, diff and diff methods, particularly a traditional approach called two-way fixed effects estimation, this can yield big problems with our effect estimates. It can be very biased, both in sign and magnitude, if there are time-varying treatment effects under this staggered adoption. So if the treatment effect is not like immediately there's an effect and that effect is maintained over time, which feels pretty unrealistic. So one solution to this is basically to think about this idea of stacked policy trial emulation, but in a more formal setting. So the idea is that we would group units that are treated at the same time. We would estimate the effects for each of those groups, and then we would be clever about aggregating them. So we would estimate treatment effects for the Arizona and Connecticut group at all of these times, and the Alaska, Colorado, Delaware group at all of these times, and the Alabama, PA group at all of these times. And then we would just sort of average them in a clever way, maybe based on relative time to get sort of an event study, for instance. This is a method by Callaway and Santana. It's seen huge uptake. It's quite nice. It's a clever approach. The other broad class of methods that I want to talk about is something called a synthetic control. The big idea here is that we're going to use information in the pre-implementation period from both our exposed and unexposed units. And we're going to construct a weighted combination of our comparators that mimics the outcome trajectory of the implementing unit in the pre-policy period. So all of these gray dashed lines, for example, might be outcome evolutions in a bunch of comparator states, and the thick black line could be our treated state. The synthetic control method constructs a weighted combination of these dot dashed gray lines, our comparator units, that looks kind of similar to the treated unit. It is very similar in the fact that these have the same mean over time. If you just sort of flattened out these lines, the black and the red would have the same, they would coincide with each other in the pre-period. And so the idea is that while we have this weighted combination of comparator states that looks like it could be the treated state in the pre-period, and then we just extend that weighted combination out into the post-exposure period and compare it to what actually did happen in our treated state. So our effect estimates at any time would be the difference between the black and the red line. I will say this is totally made up data. It doesn't mean anything. This is purely an illustration. Just keep that in mind. But the idea, so we've got this weighted combination that we're going to extrapolate forward as a good guess of what would have happened to the treated unit in the absence of treatment. A useful variant of the synthetic controls method is called the augmented synthetic controls method. Liz, Beth, and I have used it a lot in our own work, and it gets you a better pre-treatment fit. So this red line could look closer to the black line by incorporating covariate information into the model in a clever way. It's a paper by Eli Ben Michael, Avi Feller, and oh gosh, I forget Rossian's first name. Sorry, it's in JAZA. Okay, so that's a little flavor of methods. Let's kind of wrap up here. As we've seen in the past 50 minutes or so, good study design is really critical. Policy trial emulation, it provides a framework for thinking about high quality study design for policy evaluation. And again, the big idea is you want to think about the trial you would run if you could, and then try to get as close to that as possible. because the closer that your non-experimental study aligns with this hypothetical target trial, the more comfortable you can feel that you have designed a good study, and also the easier it is to communicate your study design to folks who might be more familiar with clinical trials or who might be skeptical of observational studies. So by making clear, explicit head-to-head comparisons on all of these 7 components between a hypothetical target trial and your non-experimental policy evaluation analog, you can very clearly articulate the similarities and differences between those 2 studies across all 7 components. In that Annals of Internal Medicine paper that I wrote with Beth and Liz, we have in the supplement a table template that you can sort of fill out and include in your policy trial emulation papers to explicitly do this. A table is a nice sort of visual format for this. And also, we've noticed that this framework, by mapping your non-experimental trial onto the framework of a trial, it makes it easier to communicate your results and your study design to people who are more familiar with clinical trials, and it helps your readers, reviewers, and editors kind of calibrate their confidence in the results of your trial. So good study design is really, really crucial, but it is not magic. Policy trial emulation does not guarantee quality. An emulated trial is not a trial. And calling something trial emulation doesn't mean that the trial was emulated well. This is why we want to do explicit head-to-head comparison on all of these components, because we're going to have to make trade-offs. I will, however, say that just a randomized trial itself does not guarantee quality either. I'm sure we've all seen sort of bonkers randomized trial reporting where it's just a badly designed trial. So just because you've randomized doesn't also mean that you get magic. Randomization is good study design, but again, doesn't guarantee quality. Finally, there's a whole arsenal of statistical tools available for high-quality policy evaluation, and there's a lot of work geared towards making those tools accessible. In particular, our work at the methods core of the Hopkins ALACRITY Center is really geared towards making some of these methods accessible through things like webinars. So keep an eye on the center and our methods core because you're going to see a lot of innovation coming out of us. The key goal in all of these methods and all of these approaches is often to estimate a good proxy for what would have happened in the absence of the policy. And there are just sort of different ways of getting that, but that's the key goal of everything here. And just doing it in different ways, making different assumptions. That's where some of the innovation is happening. Finally, a lot of this work is really multidisciplinary by definition, almost. Rigorous policy research requires collaboration across disciplines. You have to blend quantitative and qualitative approaches here. And working across fields is really crucial to improve communication of your results to stakeholders, policymakers, just sort of the community in general, and it improves the impact of your work. Multidisciplinary work is hard. Everybody speaks a different language, but it's really fun. Very pro. Finally, just to wrap up a bit, there are a ton of more resources here. So through the ALACRITY Center and otherwise, so in the appendix of or the supplement of our Annals of Internal Medicine paper, there's a sample trial emulation comparison table and a template that you can fill out. And the ALACRITY Center also has many more publicly available methods trainings. I shortened the link. It's tinyurl.com/alacrity-methods. Check that out and keep an eye on what's to come. Thank you so much for your time. I'm really looking forward to questions and discussion.
Wonderful. Thanks so much, Nick. That was great. Really good introduction to these ideas. And we have about 15 minutes for some questions, which is fantastic. And we have some great questions that came in. So I will try to summarize those. And there's 5 that I've tasked for now to, and I think we can probably get to them all. So again, thank you. And actually, the first question that I'm going to go to might really just build on your last slide. But the question was, are there any good resources you would recommend for how to approach this in terms of how to implement? Is sort of, would you mostly say, go back here?
Yeah, I think certainly there should be more resources, which is part of the reason that we're doing this, is we're trying to make more resources available. I would say that our annals paper is really helpful. We thought and we got a lot of help from editorial, the editorial board there on building something that is really useful and that folks can kind of fill in themselves. There are certain challenges that are really difficult to overcome in terms of like building resources. In particular, like the driving principle of target trial emulation is, I think it's just think about it. And so there are, in some places, there aren't really many shortcuts to like really deep thought with collaborators and stakeholders. But this paper is a nice framework for, I think, thinking through some of these issues.
Great.
Shameless plug.
Yeah, and actually, while you answer another question, I'll try to. I'm also affiliated with another center, which is more opioid policy focused, but they have some webinars that get into a little bit more of the weeds of the different statistical models in particular. I'll try to find that and put it in the chat. But that's a nice segue to another question, which actually comes from a fellow ALACRITY funded collaborator up at the Cambridge and Harvard ALACRITY Center. So nice to have that connection. And so that question was someone curious to hear about the relative benefits, drawbacks of this trial emulation approach versus commonly used econometric methods like difference in differences. So I think maybe could you just talk, you had a couple of slides on those sort of statistical methods and sort of just, is it a versus or is it that really they sort of complement each other and talk through that?
That's a phenomenal question. I would not, this is in no way a versus. I'll actually sort of go back here. So everything kind of up until this last section of the talk was geared towards design thinking. And I think those principles are really applicable sort of regardless of the method that you use. We're thinking like diff and diff is sort of a statistical tool to estimate that estimand, that quantity of interest, and to answer the question. But diff and diff is going to fall totally flat if you put a bunch of like poorly considered data into it. You'll estimate something, but it's not really what you want. Perhaps, or you just sort of run into challenges. Like diff and diff is kind of it's partially a design, but it's kind of a method. Like it's a little hairy. Here, what we're thinking about is ways to build a study, identify the units that you want to think about, identify the data that you have available, and then get all of that set up and ready to put into an analytic framework of your choosing, like diff and diff, like a synthetic controls, like event studies, sort of like insert econometrics method here. That high quality study design we found is really, really useful to overcome some of these key challenges in ways that are not necessarily analytic or methodological, but in thinking really carefully about design, we can kind of smooth over some of the problems that we might run into in diff and diff, in sort of other approaches without thinking carefully about design.
Fantastic. So, and I'm trying to do nice segues between. So this might be a nice segue question to get to next, because it relates to this sort of design. And you talked a little bit in the talk itself about this sort of issue of the sort of future, looking into the future, and the dangers of that. The particular question is around. Could you go into more detail about what makes it acceptable or not to sort of look into the future in defining like the comparison group? And in particular, one aspect of that is around wanting to compare different levels of implementation. So maybe we have like high and low implementation of a given policy and sort of you don't know that and on day one. You know, kind of need some time to see which states or entities do implement, you know, more versus less. So is that the kind of thing that someone could look into the future for? And just could you reflect on that a little?
Yeah, that's a great question. This is, I would say, the hardest part of the whole framework. So excellent job. Like, just get, this is the hardest question. Um, and I feel bad giving a statistician's answer, but the answer is it depends. And I think you want to be really careful about this, in part because the issue that arises, the reason that it's potentially bad to look into the future, is if policy implementation or level of implementation, however you want to think about your exposure, is related to outcomes either before or after the implementation, right? So if there's some reason that leads a unit to implement in a particular way, and then you look after that, you're potentially, well, you are introducing bias. Um, and so uh, we want to avoid conditioning on post-exposure information as much as possible, but also there might be some flexibility here. You want to think very carefully about what is impacting outcomes and what is your exposure. So maybe you could say you've implemented this to a certain level for like a month, and then you start looking after that. Maybe that's like, could be tricky. Um, it's really, really context dependent, and you want to think about what you're measuring, what your policy of interest is, and how those dynamics sort of evolve together over time. Um, and that's kind of what leads to the decision there. Um, it is there. I will say if you have a lot, if you have like a relatively large sample size, so if you're looking at like clinics and they're implementing a bunch of or you have like a lot of clinics and they're implementing a policy with high fidelity, low fidelity, something like that. The larger your sample size is, the closer you get to more of like the standard epi target trial emulation framework, and people have been thinking about defining exposures in that setting more rigorously here. The challenge with policy is that oftentimes you don't have a small sample size, and so the considerations become different, I think, as n gets larger. So think about dynamics of outcome and treatment implementation and sample size, and I think that can hopefully clarify things.
Fantastic, thank you. And yeah, many of these are the things that it is hard to answer in 2 minutes, and sort of this is where engaging, like your points earlier about engaging with the subject matter experts and really digging in helps. Okay, two more questions I'll try to get to. These are actually here's I'll go to this one, which is I think still in the sort of broad general one of the big challenges, which is co-occurring. Actually, these are all these are like the things that we all stress about.
Yeah.
How to handle co-occurring policy changes. So there's often maybe either policy changes or just other sort of co-occurring social or economic factors or other, again, sort of changes, things changing that also influence outcomes. So can you talk more about any best practices on including or adjusting for these other influences or other kind of time varying factors?
Yeah, I think Beth Ann Griffin has a paper thinking about some of this. Maybe if somebody could find it and put a link in the chat, that'd be great. Long story short is it's really hard. So if you have two policies, for instance, that are always implemented in a bundle, and every unit that implements these policies implements them simultaneously, you cannot study them separately. You can only study them simultaneously as a bundle because there's no way for you to look at one without the other. And so if there's some amount of space between them, maybe you can look at one getting implemented in a short period of time and then what happens afterwards. Um, I think the answer to this is, unfortunately, it's really hard. There's oftentimes these things do happen. It's really, really tricky. And I think one way to do it carefully, if you have things that are happening not necessarily as a bundle, or by co-occurring, you mean happening in the same year or something, like if there's daylight between the two policies that you're implementing, you could study one before the other gets implemented. So you could sort of restrict your follow-up period until the other one gets implemented and then maybe look at the combination. I think it's just clever thinking about, I think my strategy would be to, among your policy implementation or implementing units, look at the timelines of all of these implementations, see where there are gaps, kind of see what you can do, and then maybe cleverly think about follow-up or maybe defining your exposure in a different way, outside of the papers that Liz just put in the chat.
Fantastic. All right. I think final question, which is about, it kind of gets to the structure of the data. And so the specific question is, what if you have annual data and the policy happened in the middle of the year? Is the start year the year before? Kind of maybe you can sort of broaden out to talk about like the temporal scale in general.
Yes. Okay. Temporal stuff is really interesting, in particular in diff and diff. There is, I will say, ongoing work on the extent to which like time aggregation matters by Laura Hatfield at NORC. And I think in that case, right, if you have yearly data and the policy happened at some point in the year, you want to think about, okay, when could the outcomes have started being impacted? And maybe if the policy was implemented in March, maybe then you consider the policy having turned on in that year. Again, it kind of depends on the context and thinking about with subject matter experts about what it means for the policy to have been implemented, and then making kind of case by case decisions there about each implementing unit and whether you count their year in which they implemented the policy as it being on or off.
Thanks. Yeah, and I'll just add, this is one of the areas where having the individual level data can be incredibly helpful. I work on a study around pregnancy and the nuances of sort of when someone is affected or when a birth might be affected by a policy, with the sort of 9 months, gestation and all that. So it can get really complicated. If you only have the annual data, it's going to be more limited in what you can do. But if you have the individual level data, you can be much more nuanced about how to define things and timescales and that type of thing. So.
Also, I'll plug qualitative work in that setting too, and working with experts and the people who were implementing the policy, and kind of understanding what was going on the ground through qualitative work can be really, really powerful in that setting.
Great. That is a great sentiment to end on. I think we as a group are big proponents of true mixed methods work where we can use the qualitative insights to help guide our validity of assumptions and, as you said, design. So that's a fantastic note to end on. And I believe one of our online trainings is even on mixed methods or qualitative
I think you're right.
So go to the link on the slide. Thank you all. This is fantastic questions, great engagement. Thank you, Nick, for presenting this. And stay tuned, everyone, for any additional upcoming seminars. So again, thank you all and have a great rest of the day.
Thanks so much.
Thanks, everybody.